Good.
Will they tell you why they're unsubbing?
Yeah, I don't know. They'll just ghost us.
Let me practice.
Yeah. That's good. We're good. Okay. Well, I have a medical question. This probably won't be a very long episode unless we get sidetracked, and then who knows what happens.
It happens.
Yeah. But, yeah, I have a medical question. So, and we talked about this a little bit, but I want to talk about specific scenarios. So when someone is getting treatment, we want them to get treatment all the time. I want to talk a little bit about specific diagnoses that really don't require ongoing treatment and what we would use instead of that, or what we would recommend doing with treatment. And so a few of them stand out. For example, like if you're an amputee and you've been an amputee for 2 years, I mean, you don't really need to go to unless you have other stuff going on. Right. But for your amputations, there's not a whole lot of ongoing treatment for that. So usually we would say try to go to your doctor every couple of months, tell them what's going on, yada yada. But with an amputee, I mean, you know, I am still an amputee, and then 5 months later, I'm still an amputee, yeah. And so what do we tell those clients?
Yeah, that's come up before. It's a good question, and we've talked about it a little bit before, but mostly it was some of the lifelong mental health conditions, like a learning disorder, autism, intellectual deficits, stuff like that, or like a traumatic brain injury. You know, you had a motorcycle wreck when you're 19, you're 50. Now, you still had a motorcycle wreck with a traumatic brain injury when you're 19, so there's still going to be some residual problems. With an amputee with more physical limitations, we have to get it documented, first of all. So we would probably go back and get the records to when the amputation happened. And what Social Security is really going to be looking at for an amputee specifically is if they're wearing a prosthesis, if the prosthesis is fitting. That seems to be the big thing. It does take some time to get a prosthesis properly fit so it's not hurting the area where it fits to, stuff like that. And then there are going to be some instances where you just can't. I mean, there's not.
Yeah.
They can't fit you with one. And you're right. After that, you know, do you need to go to the health department, you know, every 90 days to say, yeah, you know, he still doesn't have a leg, or no, he still doesn't have an arm. You know, it sounds funny, but it's not. And no, the answer is no. I mean, if it's there. However, we would need some kind of documentation from an ongoing source that you're having problems because of it. And sadly, the only way to provide that would be medical records. So would you know, I'm going to speak out of both sides of my mouth here. Would you need to go to the health department? You had an amputation 2 years ago. You got a prosthesis that fits okay, or you have a prosthesis and you tried and it's just not working, and therefore you're either hobbling around, or if it's an arm or a hand, you're trying to learn how to work one-handed, not work, but work your life.
Yeah.
From a one-handed standpoint. Really, the only acceptable records that Social Security would look at would be a medical provider. And it seems kind of silly. And like I said, I find myself speaking out of both sides of my mouth. No, that's stupid. You don't need to go to somebody to say, yep, they still have an amputation. Okay, well, not for that reason you don't need to go, but you do need to go for you to say, just a document, listen, you know, I can't get from one end of my house to the other. You know, I have to hug a wall, or I can't make a simple meal anymore because, you know, I'm missing an arm, especially if it was a dominant arm. You know, I'm right-handed, and that's, you know, I had a right below elbow amputation. That's going to cause some significant problems. Just the improvement from the time of the amputation until you get some therapy, and, you know, again, if they try to do a prosthetic and it just didn't happen, there's just going to be a pretty significant amount of time that passes, and eventually you're going to be like, I don't want to go to the doctor for them to basically tell me, hey, we told you, 9 months ago when you were in here that we've done all we can. And of course, from Social Security standpoint, all they want is just some kind of documentation that you're still having problems. So I'm giving two different answers. Do you medically need to do that to verify that the condition that you say you have exists? No. No, you don't. But do you need to go? Yeah, you probably still need to go, just for them to document. Mr. Smith came in today, and we did a below elbow amputation on him in November of 2023, and blah 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 blah. And he's still complaining of not having the ability to do just simple tasks, getting a bowl out of a cabinet, all sorts of stuff like that. So that would help. Another physical one that comes up is seizures and headaches, migraines. What we see normally in these is that, especially if it's a traumatic onset of seizures, which that happens sometimes. You live your life, and at 43 years old, you have the first seizure, and then 2 weeks later you have another one. What we find mostly is seizure disorders. They put you on an anticonvulsant, Dilantin, Tegretol. There's a ton of them.
Yeah, Keppra.
Kepra's a big one.
Yeah.
And the thing is that 95% of cases with a seizure disorder, you're going to respond well to treatment. The only treatment that Social Security is going to be looking for in that, if you have a seizure disorder, is they want to know periodically what your blood levels are, because if the Keppra, the Tegretol, the Dilantin, whatever you're taking, if it is not at therapeutic levels, then they're not going to allow your case. You're going to say, well, if dude was taking his medicine like he's supposed to, and if it got up to therapeutic levels, but he's still having seizures, so you're not really going in so much for treatment, because a lot of times what happens is you go to treatment and you go to the ER and you amass a stupid bill, because every time you go to the ER, you amass a stupid bill, stupid expensive, and you just stop doing it.
Yeah.
Okay, your family's like, oh my goodness, look at him, he's zoning out again. Or if it's like a grand mal seizure, which is the big one, that you're flopping, you're actually on the floor. After they've seen that happen a few times, what they're probably going to do is they're probably going to stick their hand in your mouth to make sure you don't swallow your tongue, and they're just going to wait it out until you stop convulsing and stuff like that. You're not going to go to the ER every single time you have a seizure. You are not, after a while, going to go to the ER every single time you have a migraine that, they'll give you a shot usually of some, something to help you. It's usually some kind of narcotic, but, and that helps you, but you've amassed a stupid expensive ER bill.
Yeah.
And if you're having them frequently enough, I'm not going to mess with it. I'll do what I normally do, which is I retreat into a quiet, dark, cool place, and I stay there until it goes away. And so back to our question, do you need medical evidence to show that, you've continued to have 3 migraine headaches a week, or 5 migraine headaches a month, or 5 seizures a month? No, you don't need medical records to show that. But with the seizures, you're going to need to show some blood work periodically that you are taking the anticonvulsants and they are at therapeutic levels, but you're still having seizures. And for migraines, we suggest that our clients do a diary. And I'm talking about writing a book or becoming Shakespeare. I'm just saying a notebook, a piece of paper, a small notebook that you have just somewhere that you always keep it. And, it's March 7th, had a seizure, did the normal stuff to get rid of it. And then somewhere in that diary, the normal stuff, 3 hours, laying down, eyes closed, lights off, curtains drawn, making sure nobody in the house is making any noise. He's doing that several times a month. And you have a diary of that, and we actually present it to Social Security. Well, listen, they're not going to go to the ER every time because it's not practical for one, and financially they just can't do it. If you're expecting them to go to the ER every time they have a seizure when they're having 5 of them a month, that's not going to happen. It's not realistic for Social Security to expect that, and therefore we're not going to play that game. It's not realistic for me. I have 5 migraines a month. They keep me out of pocket for 3 hours at a time. Sometimes the recovery takes as long as a day. I'll just make a diary of that. It's not reasonable for you to expect me to go and amass a stupid, expensive ER bill for them to give me a shot. I'm going to get the same kind of remedy, but I'm just not going to get it as quickly as a shot, and I'm not going to amass, a $500 or more bill doing it several times a month. So again, I find myself speaking out of both sides of my mouth. You always need medical records to prove a condition, but I don't expect it to be unreasonable. So I guess that's my dual answer to the question.
Yeah, I mean, we're not going to be able to work a case without any kind of evidence.
Right.
So it doesn't necessarily need to be this intense, every month with a specialist and every month with this guy and every month with this provider. But we have to have some piece of evidence. And I would imagine the ADL is also super important for those type of cases.
Absolutely.
If you're an amputee, use your example of, say it's their dominant limb, their dominant arm or hand. Social Security will send the client an ADL, an activity of daily living, and that's your opportunity to talk about, I have trouble doing laundry because of this amputation, and I have trouble doing washing dishes and folding laundry and sweeping, and
Sure, yeah.
I can't go to the grocery store by myself, stuff like that. I would imagine that's extremely important for all cases, but especially
Absolutely.
something like an amputation.
Absolutely. Yeah. I mean, upper extremity involvement, the ADL, you're going to have problems doing things that people with both limbs, both upper extremities still have. And there's going to be a long and arduous learning curve. Mm-hmm. If you're 50-something years old and you've had both limbs all 50 years, and all of a sudden, for whatever reason, you have to have, one of them removed, there's the trauma. But then there's that learning period of doing things one-handed, lower limb. There's that learning period of balancing, of learning what you can't do. Certain things that, there's the obvious things like, okay, well, they're going to have difficulties walking, getting around and stuff like that. Yeah, try to get in and out of a car without both legs.
Yeah.
If you're watching this video, just try to do that. You're watching this video, and I won't get gross and crude. If you're watching this video, tomorrow morning, try to do your morning hygiene ritual, showering, bathing, cleaning, brushing your teeth. Try to do all that with your non-dominant arm. And your dominant arm, you don't get to use at all. Try to do that. And you will see how absolutely horribly hard it is.
Yeah.
And it's not something that you overcome in a week or a month. It's, you're basically, your body's been doing something for decades, and all of a sudden you're telling it, I can't do that anymore. You're going to have to do it a different way. We are really fantastically adaptable creatures, but we don't adapt quickly.
Yeah, it takes some time.
Yeah.
Yeah, that makes sense. So I'll give another example. This one's more of like a category, not a specific condition.
All right.
Well, I'll use a specific condition, and then I'll go into what I was going to say. So we'll use degenerative disc disease, because that's very popular, or arthritis or herniated disc. So their back is hurting, they're having trouble walking, standing, stooping, squatting, all of those words, lifting things. I ask the client after that, when I'm screening this person, I'll ask them, what are they doing for treatment? Because the question is, okay, you have this wrong with your back. Are you going the pain meds route? Are you going to do an operation? Are you getting the shots? Are you, what are you doing? What are we working with here? Every once in a while, this doesn't happen super frequently, but every once in a while, I'll talk to someone who who tells me that they're at maximum medical improvement, and that's an actual medical term. So I don't want to
Oh, yeah.
I don't want to speak too much about it because I'm not a doctor. But MMI, maximum
MMI.
medical improvement. If they get to that point, that is their doctor telling them essentially,
We can't
look,
do anything else.
look, man, there's not really anything else we can do.
Yeah, we see that mostly in worker comp settlements.
Mm-hmm.
You know, MMI, maximum medical improvement. It is not a term that Social Security or the judges care about, by the way.
Mm-hmm.
What they do care about is somewhere in the medical records it says that, or it says it in a different way. You know, Mr. Smith has come in. You know, we've tried, you know, what they call radical treatment, which would be cutting you, you know, surgery.
Yeah.
We've tried conservative treatment, which is usually physical therapy, exercises. Somewhere in the middle, ongoing maintenance therapy is usually the medication, and that does include the shots, the epidural steroid injections. But yeah, somewhere along the line, they're going to say, "We've done what we can for him." So, what you're going to follow up with the question of, "Are you?" Did I interrupted you? So.
Yeah, no, that's what I was gonna primarily talk about is just MMI and how we go about that because, but you know, back pain or I mean, it could be anything. It could be any kind of diagnosis. But to me, having your doctor literally tell you that we've done all we can, that seems like that client is going to stop going to the doctor.
Sure. Yeah.
And
Exactly.
probably the most common thing we see after that is just like pain management for
Right.
degenerative disc disease. Something just to instead of curing it, we're just trying to put up
Maintain.
with it, like
Yeah.
maintenance.
Yeah.
Yeah, like you were saying.
And you're absolutely right. And you know, we went to, you know, our first example, you know, an amputation, you know, that's pretty drastic. But you're right. Things that are more common, which
Yeah.
degenerative disc disease is, any kind of back disorder is, I think it's number one as far as allegations in disability claims nationwide. But you're exactly right. You got to think about that. If you were from the outside looking in, and you're like, you know, what has this person done to address the he's got a herniated disc? What has he done with that? And again, Social Security, what they're looking for is, you know, they'll almost always start out with very conservative things. You know, you need to do these exercises at home, and hopefully it'll loosen up your back to where you won't be hurting so much. But then you come in, you know, 2 months later, and you know the back problem is still really bad. It's shooting down my leg all the way into my toes or whatever. And so they're like, well, let's give you, you know, an ESI, an epidural steroid injection, and that's literally, it's a shot in the back, and it's, you know, supposed to kind of numb the area. You come back in 2 months later, and they're like, you know, you're probably a surgical candidate if you want to do that, but it's up to you. And you're like, well, yeah, I can barely get out of bed every morning. Let's do something. And you have surgery, and you know, here's the bad news, guys. I speak from personal experience here. Surgery works for the first 5 or 6 months. You're going to feel like a new person, and thank goodness they did that. They got it all squared away. I'm good. Oh, wait a minute. Feeling a little bit stiff today, and 8 months later, you're at the same point. That's what I hear from 90% of my clients when it goes to surgery, specifically a laminectomy. So you and your doctor talk about it, and it might work for you because it does work for some people. But for the majority of cases, especially for folks in their 50s or older, and they have that, they'll say the same thing. Man, for a few months, I felt like a new person. I was a Superman, and I was able to do everything. Then it kind of got bad again, and now it's as bad as it ever was, or sometimes it's worse. So let's say you do that. So you've gone down from exercises, then you had the ESIs, the injections, and now you've had the surgery, and several months later you're like, it's still there. It's still shooting down into my leg, which indicates that there's some neurological involvement. It's hitting a nerve somewhere. What are you going to do? You're not going to do another surgery because now you're mad because the surgery that you had didn't work. They're just going to prescribe stout pain medication for you. It's almost always going to be an opioid, and it's going to work, but you're going to be loopy, and they're probably going to say you can't drive or operate heavy machinery on this. There are going
Yeah.
to be some restrictions. And I say everything, and I went through the list like I went through because that is exactly how Social Security will look at that specific disorder. Well, really any kind of disorder. Did you start with a conservative treatment, and then you move to kind of a more in-depth treatment? You went all the way to what they call radical treatment, which is surgery. They cut you. And then after that, if that didn't work, you're kind of on a maintenance program there. They're gonna give you pills, or they might have you come in every month for a shot. I mean, and it's all pain relief at that point.
Yeah, and that is valid treatment. That's valid medical records.
Yeah.
If a client gets to the point where they're not trying to have any other surgery and they've tried everything, like you said, and they're walking with a prescribed cane and they're on heavy narcotics, and they just see their pain management doctor every 1 to 3 months, that's fine. We would put that pain
Sure.
management doctor or provider as a medical source, and that's valid.
Yeah, but let's say, back to our question, let's say all that happened, and it all happened 2 or 3 years ago. Okay, when you had the back injury or it got so bad that you couldn't work anymore, you went in, they gave you exercises to do. You went in, they gave you epidural steroid injections, and you had that for 2 or 3 months. You went in, you begged them, cut on me, please, 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 do something. My pain is excruciating. You had that, and here we are 2 or 3 years later. What happened after the surgery? Well, it's going to be documented because they're going to bring you back. Your surgeon is always going to bring you back. How did it do? And two months later, they're going to feel like they're the best surgeons on planet Earth. We solved this man's problem that he's been dealing with for years and years and years, and blah blah blah. And then the wind is going to go out of those sails because 5 months later, their client or their patient is going to be coming in and saying, "I'm having the same problems, and I think it's getting worse." And so all that happens like 3 years ago. Are there going to be medical records? Maybe. There may just be like, every 6 months or so they show up to the doctor and he, are you doing any better? No. Okay. I'm rewriting you a script and here's a 90-day supply of Lortab or oxycodone or whatever. And pain management is going to be the same way. Pain management, there's not really going to be a whole lot of treatment involved, as in, let's try this and let's try this. Pain management is just here is the pills that we're going to give you. And by the way, every time you show up, you got to pee in a cup because we got to make sure that we're giving you this medication. It better show up in your urine because if it doesn't, you're not either not taking the medication the way you're supposed to, and that can be really problematic for you with Social Security. They're going to wonder where's the medication going to, especially if some of the pain management companies make you bring in your bottle and you have three tablets in it left. That's where it should be. And then they take your blood and they're showing either none of that medication or just a trace of that medication. Now they're like, you're giving it away or you're selling it or something like that. And it can turn into an absolute mess. Again, speaking from experience, I've seen this with many of my clients. So pain management, it is a natural progression, but if you're looking for pain management records to show treatment, the only treatment is that they're going to make sure that you're taking the medication that you're supposed to, and they do that with a urinalysis, and they're going to ask you, on a scale from 0 to 10, for since we've seen you last 3 months or so, what's your pain level been like? It's an 8. Okay, they still need it, and they'll write you the script or whatever. You're not going to get a whole lot of, range of motion here. We're going to do a straight leg raise, straight leg raise. They do 2 of them. They do one of them where you're lying on your back, and they lift your leg up, and if it hurts, they say, okay, well, they got to 45 degrees, and they're just looking at your face, basically, to see if you're wincing in pain, or they got to 90 degrees, you should be able to get to 90 degrees, or you're sitting at the edge of the exam table, and they lift your leg, and, he got to to 90 degrees, and he was wincing. So they do that, and that just shows neurological involvement. But you're not going to see a lot of that in pain management. So, my long answer to your short question is, you have to go somewhere to basically report that you're having the limitations. The ADL is going to be great, and you brought up just the general ADL, the activities of daily living form. If you have a seizure disorder, most states have a seizure questionnaire. If you have there's other things that we haven't talked about on the podcast that are a little bit more specific. Chronic fatigue syndrome. You have chronic fatigue syndrome. There's a chronic fatigue form or a questionnaire that they send out. The pain questionnaire is universal. I think every state has that. They're going to send that out if you're alleging problems with pain. So you have these things, and they do go a long way. The migraine headache diary goes a long way, believe it or not. That's kind of Mickey Mouse. I'm just writing it with my hand on notebook paper. Yeah, you are. And you're keeping a diary of every time that happens. And somebody looking at that is like, oh my goodness, look at this. In the month of March last year, you had 6 migraines, and they pretty much every one of them took you out of pocket all day. Yeah, that's kind of the way it is. That's disabling.
Yeah.
So.
Okay. Well, I think that's a good place to end it, unless you have anything else to add.
Nope.
Alrighty. If you have a question about your disability case, drop it in the comment section below, and we will do our best to answer it in the next episode.